Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Sagg, Professor of Medicine and Infectious Diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. In this episode of Going Antiviral, we present a panel discussion as part of a dialogue series latest update on urgent virus outbreaks, sponsored by the IAS-USA, that was presented on January 15, 2025. The panel was moderated by Dr. Carlos del Rio from Emory University, and the panelists included Dr. Yvonne Maldonado from Stanford University, Dr. Peter Chin-Hong from the University of California, San Francisco, and Dr. Jason Zucker from Columbia University. All of the panelists are experts in viral diseases, epidemiology, and treatment. And with that introduction, let's begin.
Hello, good afternoon, good morning, or good evening, depending what part of the world you're at. My name is Carlos del Rio, and I'm a physician, infectious physician at Emory University, and I'm also in the board of the IAS-USA, and I'm delighted to be today moderating this discussion in which we're going to talk about updates on viral infections, some urgent data, some new data on viral infections in this winter of 2025. I have the pleasure of having as discussants with me Peter Chin-Hong from the University of California, San Francisco. You know Peter, he has been a frequent guest in these conversations. I also have with us Yvonne Maldonado, who is from Stanford University. Bonnie is a pediatric infectious disease specialist, again, has joined us a lot of times, and she is a member of ACIP and somebody who's really, highly respected in the field of vaccinology. And we are being joined this time by Jason Zucker, who's at Columbia University. And many of you know Jason, and if you don't, you need to get to know Jason. Jason is my go-to person when I have questions about mpox. And the reason we have Jason with us is because we will be talking about mpox. There's some recent new data on mpox that I think we all need to hear. So welcome, everybody. Delighted to have you with us. Why don't we start with you, Jason? Let's talk about mpox, since that's where we are. So mpox, we had the big outbreak primarily affecting MSMs. MSM, we responded quite effectively. We vaccinated people. The community responded. We worked very closely with government, industry, community partners, the health agencies. And the outbreak pretty much, went away, but didn't totally disappear. We're still seeing individuals with mpox. That's mpox clade 2. But there's also an outbreak of mpox clade 1, which is occurring in Africa, has continued to occur, and is now causing significant illness. So tell us, where are we, and what are we as clinicians? When should we suspect it? What do we do? How do we approach now, especially now that we know that ticagrelor really doesn't do much?
Well, there's a lot of things going on in that question. I mean, I think the most important thing is to remember that mpox is absolutely still here. Just because we're not seeing hundreds of cases a day doesn't mean it's not still around, with US cases somewhere in the neighborhood of between 30 and 50 cases per month. It means it's really important that we keep it in our differential. So when patients are coming in with skin lesions, proctitis, and other epidemiological risk factors for mpox, it's really important that we think about it and test for it, because it's the only way we're going to be able to sort of identify it early and keep people aware of it so that they know that they need to isolate and they know what they need to do. On the other side of that is, the prevention side of that, and it's remembering that we still need to continue to offer vaccination. Very early on in 2022, it was very easy to vaccinate people because people really wanted vaccination. But as there's been less cases and it's sort of been less prevalent in their day-to-day lives, people either forget about it, are less excited about being vaccinated. Do I really need this vaccine? And so it's really important that we make sure that people are fully vaccinated, meaning they got both of their shots, and making sure we do catch-up vaccinations for those who only got one shot and offering vaccination to those who haven't received any.
Thank you. So really important that we talk to our patients, we educate them, and we let them know. So Peter, you're in the consult service, you're called, there's somebody with newly diagnosed HIV presents with mpox, they're having a lot of pain, you manage their pain, but what are you doing now? Do you still put them on ticagrelor, or based on the data you don't? What are you doing?
I think in the old days we would put them on ticagrelor. I think right now we're trying to get them in a study the CDC study, but I know the data in Africa doesn't support tecovirimat right now, but I think a lot of people on the ground still have questions about whether or not that's generalizable to the population
So
here.
Peter,
And then,
can I mention
Yeah.
something though? I was on the DSMB for the STOMP study and we reviewed that data and I think it's out already and it's pretty clear, unfortunately, that tecovirimat doesn't work. I don't know what you think as a clinician, treating the patients, but the data, we went over the data backwards and forwards and unfortunately it just doesn't look good, even in
So-
the even outside of Africa.
So do you do Cidofovir? What else do you think
yeah,
about?
I mean, we've used Cidofovir in the past. We've had a patient with mpox in the eye, and we've gotten Cidofovir in particular to be used. So those are other options as well. Symptomatic relief. Those are some of the other interventions that we use. But I think everybody's had held on so long to that tecovirimat halo. I mean, and again, this is where anecdote meets study, and I think so many people have had individual experiences of success with it. That's why I think it's tough to accept that data.
So,
Well, and
I
the
think
and the NIH and the clinicians involved in the studies, the STOMP and other studies, are in the process, and I know, Jason, you may be able to speak to this, but they're in the process of reformulating their approach to the clinical trials. So it may be that there could be other combinations, say, for example, with Cidofovir or others that may be coming down the pike. And the other thing I want to remind you about the vaccine, which Jason rightly pointed out, is we really need to remember to get that second dose because it really makes a difference. And also, if there is breakthrough disease, that doesn't mean the vaccine doesn't work, because what we're seeing with some of those second dose or even first dose or second dose breakthroughs is that they're really also related to not necessarily just time after vaccination, but also number of exposures. So the vaccines are actually really quite effective, and I wouldn't call it necessarily breakthrough disease. I think it's actually really mitigating serious disease. And I don't know, Jason, what you think about that.
I think that's absolutely true. We've seen cases of breakthrough infection in people who've been vaccinated, but the data shows that those tend to be much more mild, fewer lesions, less severe. And so, as most of our vaccines, even if it's not 100% protective from disease, it's effective in attenuating disease, and you have much less severe symptoms and potentially shorter course of illness.
So
Regarding tecovirimat, I think I'm always in a unique position here because I'm a frontline clinician in New York City. So saw a lot of patients with mpox very early on in the outbreak, and then also a senior member of the STOMP team, so got to be very heavily involved in the clinical trial. And I always tell the anecdotes is that very early on in New York City, tecovirimat was fairly limited in June of 2022, and there were really only 2 sites that were seeing patients in person, ours and one others. And it was essentially me seeing patients 10 sessions a week. And we weren't seeing them on the weekend. So every Friday afternoon, like everything in ID, we get a bunch of phone calls for people looking to be seen, and we'd schedule them for first thing Monday morning. And then every Sunday night, I'd call them to see who still needed those spots or could I make more spots available. And about half the people would tell me that their symptoms had resolved and they didn't need to come in anymore. We never were able to capture that data systematically, but I think it's important to remember that, we weren't treating everybody early on, and a lot of people are getting better anyway. And that's what we saw in the top line results from STOMP and the top line results from PALM, is that most immunocompetent people get better in a pretty similar time period, whether they receive treatment or not. To go back to the original question, I do think it's important we think about other options for people who are severely immunocompromised, because they do have terrible outcomes, high rates of hospitalizations and mortality. And the animal data for tecovirimat plus Cidofovir is compelling. Certainly there's synergy there, and not just individual drugs, but actual synergy in the animal models. And I think we really need a clinical trial to address that, because for people who are immunocompromised, this is a severe disease that we do need an available treatment as soon as possible.
And that is coming back to Carlos's question about, that immune compromised patient in front of you. It kind of falls outside of the trial, and I think that's where we're stuck.
So somebody in the chat says that we should know that the tecovirimat trials did not randomize immunocompromised hosts. So I think the drug still, along a second agent is still indicating people without an immune system to control the infection. Yeah, but remember, everybody who's immunocompromised could get tecovirimat in the trial. They automatically got tecovirimat. So But anyway, I think this is I think to me, there are three important lessons. Number one, clinical trials are important because anecdotes should not dictate what we do, and well-done clinical trials should dictate what we do. Number two, we need more research with better agents against this virus because it's not going to go away, and we need research, more research for better agents. And number three, we need to remind patients and persons at risk that the vaccine work, and we really need to get people vaccinated. And I think those are very important lessons to get, is that treatment is not what we need it to be. Vaccines do make a difference. Please get vaccinated. And I think getting that message over and over to individuals is going to be very important.
And I think there are only 1 in 4 people who've gotten fully vaccinated. I think the vast majority of people haven't gotten their second shot who are eligible.
Correct.
That's right. That's right.
Correct. So we got that virus covered. There's still a lot of questions. There's still a lot of opportunities to do further investigation and understand more. But let's move to the next virus of the day, and that is, of course, H5N1, or highly pathogenic avian influenza, or bird flu. We're hearing a lot of things, right? We hear most of the government, the message still is, no worry, this is not an issue for the general public. But then we hear about more herds of cows being infected. We hear about an individual being critically ill in Canada. We heard about who's recovering, but we hear about an individual in Louisiana who died. And so how are we digesting all this? Bonnie, I'll start with you, since you sit in ACIP and you are very interested in this topic.
Well, yeah, as you know, all of you, we've all been tracking H5 for over a decade now. I would say almost 2 decades, and we know a lot, but we don't know enough. So we know that it can be highly fatal. So the fatality rates for infected individuals around the world, which total a little around 1,000 people, is about 50% or so. But that's really incomplete data, because I don't think I trust that denominator. I think the denominator is much bigger. And so we're probably overblowing the virulence of this virus. However, we can't underestimate it either. So I do think it's a very, we know that normal flu is highly virulent relative to other respiratory viruses. So I think this is worse, but we need better surveillance. And I really think that we have not done a good job, not only in the US, but around the world, in doing good flu surveillance. We don't really understand what's going on with this virus. I think we need better information from the US. I think wastewater surveillance is one way to look at it. We need to understand transmission dynamics. So we know, for example, that cows, here I live in California, and we, as does Peter, and we are really on alert here. We have several hundred cattle herds here in California we know are infected, but we only know that because they're testing. And we know that there have been over 12,000 or so people who've been tested. And out of those, we've only seen 66 infections in the US, with 1 death, as you alluded to, Carlos, in Louisiana, in a highly immunocompromised individual over the age of 60, I think, 60, 65. And so we know that it's virulent, and we know that it could lead to disease in serious illness in humans. And we know that we have vaccine stockpile for people. But one of the things, and we talked about this, I think we've talked about this over and over, and yet nothing's changed, is it would be great to know determinants of transmission. It would be great to know mechanisms of transmission, and whether vaccines or other interventions for animals will make a difference in reducing that risk of transmission. So, for example, there's a lot of economic and political reasons why, not politics in the US, but just politics of economy, of trade, that have been limiting our ability to test, for example, cattle, or vaccinate chickens. Those vaccines are available, and they could be made available if we really thought that was a good way to prevent disease. But I haven't seen any good papers modeling vaccination of our animal colleagues, if you are animal earth, inhabitants, and to see whether that's going to make a difference. It could make a difference in the transmission to humans. And then understanding what human-to-human transmission might look like. We don't have that yet so far, as we know. But if that happened, we do have stockpiles of vaccine and we could ramp those up. So there's some good news here in that we know we've been ready for several years now with vaccines. Whether we had enough vaccines or the right kind of vaccines is unclear yet. But really, we shouldn't be waiting for a disease to show up before we treat it. We should be trying to understand what it's doing in our animal communities and how we can stop that. So not much new at this point. I do think that CDC is doing some work. If you want to look at the latest, if you go to the CDC ACIP, which is Google CDC and ACIP, and you'll find the meeting presentations. There's a nice overview of what the government and others have done so far to do surveillance for H5N1 and other HPAIs, or human highly pathogenic avian influenza. So they've done a reasonably good job there, but we need to know more and we need to disseminate that information so that we can really, we have an opportunity to prevent a serious pandemic here.
So Peter, there's influenza A on the rise. We see a lot of influenza A, both in the outpatient and the inpatient setting right now. Again, I'm going to remind you, you're in the consult service, you're called to see somebody with influenza, severe influenza in the ICU. What makes you decide whether you want to test that influenza A for possible bird flu? Let's suppose the person maybe is a dairy employee or maybe has no exposure. How do you make that decision?
I think these days, and in California, we want to probably test everyone with influenza A. We have so much H5N1 in the animal population. We've had at least 2 cases where we don't know what the exposure is, and potentially 3 cases. And, you know, I think it is something, like picking up from what Bonnie was saying, it is something that we need to, I mean, surveillance is the beginning of understanding what's going on, and we haven't done a great job of surveillance.
So really important, right? I mean, you do test for influenza A, and most of the labs or your lab or some other labs may then do, tell you whether it's an H5, whether it's an H1 or an H3, because that's what they can tell you. If it's not an H1 or an H3, then you should immediately, worry that this could be an H5, and you should then, report it, talk to your public health department, et cetera. But I think, the first thing is we look at the subtype and decide which influenza A is, whether it's H5, H1 or H3. Jason, influenza vaccination, the data from the Southern Hemisphere was that the vaccine this year doesn't look that great. So what are we telling our patients? Are we still recommending vaccination? Or are we saying, it's not worth it?
Yeah, I'm definitely still recommending vaccination to my patients. I think, kind of like we talked about a little bit earlier with mpox, there's older data that suggests that even when the match isn't great, you get less severe disease with any vaccination. And so I think there's still a benefit to vaccination to our patients, and also the ongoing reassurance that we provide every year that it may not necessarily prevent influenza infection, but it very likely will prevent you from getting more severe infection than you would have otherwise. And there's a big benefit to that. It reduces mortality, reduces hospitalizations, and those are outcomes that our patients appropriately really care about. And so pushing those outcomes, I think, is important, especially in years where we know there's not a great match ahead of time, and that people who get vaccinated may still get infections.
Yeah, but I think you really make a very important point. The match is not great, but it's not zero. There is still some degree of protection. And I think it's exactly right. We want people to get vaccinated. So encouraging people to still have time. You still have time to get your flu shot. If you haven't gotten it, please go ahead and get your flu shot. The other thing,
so Carlos, one of the things I like to say, and this is, I'm quoting Kathy Newsel from many years ago when she talked about rotavirus, and it's, is this a glass half empty or a glass half full situation? And what she said is, it's not about that, it's about how big the glass is. And we have a very big glass full of influenza, and right this point, we're just launching into the big part of the season here. We haven't reached the peak yet. If you look at the data, we're still on the upward trajectory. The hospitals, at least here in California, I don't know, Peter, if you're in the same boat, but we are really not overwhelmed, but we're pretty full. And it's mostly flu. There's a lot of RSV now that they're testing for it in adults, but there's a lot of flu out there. And those are still continue to be mostly unvaccinated people. So it will keep you out of the hospital. at this point, we're really not trying to stop infection. You can't really do that at this point. But you can stop people from going to the hospital. And that's really important because the people who go to the hospital are those over 65 and the babies. And by the way, there's a big meta-analysis looking at masks. And it turns out that some people there's modeling showing that masks had not only probably worked really well for preventing COVID deaths, not illnesses, but deaths and hospitalizations, but some suggestion that mask use may also have been useful in reducing or eliminating Yamagata B influenza because it's gone. We don't know where it went. It's gone. And again, we don't know this for sure. This is a model, and all models are wrong, but they can give you some evidence. And it appears that masking may have helped eliminate one strain of influenza. Now, whether it pops back up or if that's really true, it's not clear, but the data were pretty compelling. So we still need to prevent disease because we keep the most vulnerable of our populations out of the hospital, and we keep people from having to stay home sick and go through terrible periods of time. I mean, it's not a disease without long-term complications, even in healthy people.
Oh,
And I just
absolutely.
want to amplify what Bonnie said too. If you think about the fact that we have anywhere from 200 to 800,000 hospitalizations due to flu every year, 35% efficacy of that is, preventing hospitalization is still amazing. And the second reason we talk about flu shots, particularly in California with bird flu, is that, at least particularly with dairy workers, you want to reduce the chance of co-infection and gene exchange to make it easier for H5N1 to pick up those mutations to enter human bodies.
So Peter, let's talk about that, right? Because I was going to bring up that point. What makes the government still say the risk of the general population for avian flu H5N1 is low is because we really have not seen human-to-human transmission. And the reason we haven't seen human-to-human transmission is because H5N1 does not have the sialic acid receptor affinity to the human respiratory sialic acid, and therefore it hasn't done that. But if you were to have a recombination in which the virus would acquire the ability to now infect respiratory epithelial cells, and you start seeing human-to-human transmission, then we would be dealing with a different beast. And you're absolutely right. How does influenza do that? It does it through recombination, right? It does it through recombination. Whether it's in a human, most of the time it happens in a pig. The pig is the ultimate recombination vehicle, right? But humans can also create that recombination. So yes, we want to decrease the possibility of a dual infection in an individual, because that's where we could potentially see that recombination that will then be the one that leads to human-to-human transmission. So very important message to get to our patients. Before we move away over these two viruses, Jason, in the Q&A, somebody asked a question that I think it's important for you and for any of us to answer, which is what's the story with vaccination schedules for mpox vaccine? Somebody who's had 2 vaccines, do we still recommend, do they get a boost? What do we do?
Yeah. So there's currently no recommendation for booster vaccines. There are ongoing studies looking at this question, but I can tell you that in the UK, they've recommended boosters after 10 years. So we're certainly not nearly there yet. So currently no recommendation and no indication that we should be getting vaccination. We do get this question a lot because there's been a lot of publications looking at sort of antibodies waning. But I do feel like when we look at our epidemiological curves, it really supports the sort of effectiveness of vaccination. If it wasn't working, we'd expect to start seeing cases going up, especially given how many people are vaccinated around the same time, and that we know infections are still present in our population. And so I think we have pretty good support that at least for now, there's no indication for booster vaccination. I don't know, Dr. Maldonado, who's running the ACIP working group on this, has anything else to add to that?
Yeah, we are not going to be taking that on. First of all, there's really no data on boosters yet. I mean, we're too early in the days of the vaccination efforts to look at that. It's certainly on everybody's mind. We keep bringing it up. But if you think about this being an orthopox virus and the parallels with smallpox, and you look at the serologic response in people who were vaccinated against smallpox by very similar vaccines. Remember, Jynneos was originally meant for prophylaxis of smallpox. It was meant to prevent bioterrorists, for example, bioterrorist introductions. And so Jynneos was fortuitously available to us as a smallpox vaccine. And what we found is that people who'd been vaccinated against smallpox still had immunity 20 years plus after vaccination. So there's no reason to think, at least up front, that this vaccine immunity is going to wane. But it is something that we'll be following over time for sure, I think.
Correct. So it's I want to welcome Andy Pavia, who is a good friend and an expert in influenza, who's in the
Hey,
public.
Andy.
And Andy makes a point, says, it's worth discussing that the case of the 13-year-old girl in British Columbia, I mean, she was previously healthy. She had H5N1, and she only survived due to superb pediatric care, including ECMO and CRRT. So, I mean, this could be a very severe illness. And we need to remember, while the one in New Orleans was immunocompromised, this young girl was not immunocompromised. She was totally healthy. And let's be real clear. This H5N1 is known to have a very high mortality. So we really need to be aware of this.
Well, and Carlos, to that point, from an epidemiologic perspective, if you look at the R naught of flu is like 4 times higher than the R naught of COVID.
Yeah.
So it's nothing to sneeze at. I mean, no pun intended, but it is a scary virus. I mean, we're not ready to be afraid yet, but it's frightening enough that we should be preparing for something that could happen, in the next year, 2 years, 10 years. We don't know, but we have a real opportunity here. Absolutely.
Can I just put in one more point about bird flu I forgot to mention, which is the idea that one of the carriers are these wild birds, and they're affecting all these cats and birds and zoos. And probably that's how the person in Louisiana got it, and probably all these quote unquote unidentified risk factors for people. So there are new risk factors that are being identified, including like backyard chickens in California or elsewhere, and handling dead birds and things like that, which is not new, but I think has more priority.
So, and I would add to that the other risk factor, and I want to emphasize, is unpasteurized milk. They have been cats who have died because of feeding them unpasteurized milk. So we in infectious disease do not recommend people have unpasteurized milk, but right now with H5N1, we really, really don't recommend anybody drinks unpasteurized milk. And I think when people ask me, what can I do to prevent H5N1? I said, if you're not a farm worker, the most important thing you need to do is not drink unpasteurized milk. So, Bonnie, why are we not vaccinated farm workers?
That's a whole long story. A lot of it has to do with just, policy decisions that have and have not been made. I don't want to go through the whole thing, but I'll just give you some high points. So basically, when you vaccinate animals, if you have antibody, right, you'll have antibody to H5. Most countries won't import our beef if our beef is antibody positive, because they're so afraid, rightly so. And so that's one of the reasons why we aren't vaccinated in the US, because then we would not be able to sell our beef. Now, my argument there is that you come up with another way to diagnose, antibody versus non-antibody specific, virus versus vaccine versus wild type antibody. We were able to do that with COVID. So it's a simple fix. We just don't have the political will yet to do that because it hasn't really reared its ugly head. The other issue is this is the other issue. No, people have said, well, we haven't done studies looking at the efficacy of vaccinating animals, chickens, for example, or cows. Really, at this point, it would be chickens, vaccinating chickens to prevent the spread, because by the time a chicken is infected, like humans, they may not be symptomatic. So you may be vaccinating flocks that are already infected. Now, my argument would be first of all, we can do those studies. I mean, chickens don't need informed consent. But the other issue is, even if you vaccinated, the herd immunity impacts in a population like that could be easily modeled. We know how to do direct and indirect effect modeling to see what percentage, what's the tipping point of vaccinating flocks to then suppress enough transmission among maybe asymptomatic birds and from uninfected susceptible birds. And I think we could easily do those studies and figure out when is the tipping point for vaccinating flocks. It's not a money issue either. These vaccines could be quite cheap in chickens. So then the next step is in vaccinating people. But again, without all the other data, we don't really, I think the business end of this, agriculture, dairy is a very big multi-billion-dollar business, California as well as in the rest of the country, and starting to do screening would really impinge on a lot of the freedoms of the commercial sector. And I think they're not really excited to do that. And I think we're kind of playing to that that reluctance to get the private sector and the commercial sector involved in this kind of prevention until something really pushes them to do so. And I'm not optimistic that that's going to happen soon.
I agree with you, but I think something that I've learned recently, which is very interesting, at least I didn't know, is the cows that get infected, the infection occurs in their mammary glands. That's where the receptor is, and they don't die, but their mammary glands develop fibrosis when they recover. They first, you know if a cow's infected because their milk production goes down, but then the mammary gland becomes severely fibrotic, and then the cow actually, once recovered, really does not produce enough milk. So the impact on the dairy industry is actually quite significant. Even though the cows are not dying, their production of milk significantly goes down, and that becomes a big issue. So again, we need, I want to emphasize the importance of One Health approach. We really need to work closer.
The other One Health, Carlos, is think about the hundreds of millions of birds that have already been culled. So if you think about the impact on agriculture, it's already been quite severe. Somehow that really hasn't driven the industry or government or the partnership between the two to really start doing mitigation, because we could actually do a good job for our agricultural industry to really support. I mean, I was at the market last week, and I can't believe it. I thought it was COVID again, except it wasn't toilet paper, it was eggs. There were no
I
eggs.
can't buy eggs. I'm super anxious about that. I use eggs in everything.
Well,
by the way, I found some at Trader Joe's, but don't kill anyone.
I think the important lesson there, and I think something important for us in public health, is that something that came out of COVID is this whole idea of whether it's public health versus the economy. And public health, when you do public health, you hurt the economy. And somehow we need to get the message that actually strong public health supports the economy. Strong public health is good for the economy, and we need to keep the economy. In order to support the economy, we have to have good public health. We have to have prevention. And I think we somehow in public health need to get that message out, because there's still a lot of people saying, well, if the CDC comes here, if the public health comes here, starts doing things, it will hurt the industry. And somehow that messaging has had to change. But let's talk about other viruses. COVID, I thought we would not be talking about COVID, but we're still talking about COVID. I still get questions about
Did you want to talk about Tamiflu, Carlos?
Sure, Tamiflu.
You start.
There was in JAMA Internal Medicine this past week, there was a meta-analysis that really showed that Tamiflu in the non-critical, in the outpatient setting, it offers very little benefit. And so my question to all of you is, are you still prescribing it? 30-year-old, otherwise healthy individual comes in, calls you, has influenza, do you give him Tamiflu? And then we can talk about an 80-year-old, otherwise healthy, who comes in and has influenza, do you give him Tamiflu? What are you doing, Peter?
I think the 80-year-old is a no-brainer. The 30-year-old, it's plus minus. A lot of times the 30-year-old didn't even get diagnosed within 36 hours. So it's really, I think most times they don't get Tamiflu in real terms.
But now many, at least.
Peter, what about this? Let me ask you a question too, because this came up for me. So the CDC guidelines say that if you're diagnosed, you should be on Tamiflu because it's a prophylax against your other household members getting infected. And that's one reason to actually do it. And that actually seems to work. So would you do it in that respect or no?
Yeah, if the 30-year-old lives with the 80-year-old and the 80-year-old didn't have flu yet, just like we do in nursing homes or SNFs, I think that's a reasonable possibility, as well as thinking about prophylaxing the 80-year-old in the household.
I would prophylax the 80-year-old, and I would put a mask and isolate the 30-year-old.
Yeah, that makes sense. So let me just say,
Jason, what are you doing with Tamiflu?
I think household composition matters a lot. We think about that a lot in pediatrics, but household composition, who's at home with them? Because, you can ask people to mask for periods of time, but if they're living with 3 children, that may not be as practical. If they have a neonate at home, anything like that, or they have older relatives they care for. So I think if you have a 30-year-old in New York City living alone, it makes total sense to not provide Tamiflu and offer a mask. if they're taking care of elderly parents or relatives, I think it makes a lot of sense to offer them for the potential reduction of transmission with that mask.
Absolutely. So
Yeah,
Bonnie,
so-
Biloxivir.
Well, I'll tell you, this has been a bone of contention in the pediatric world for decades now,
That's why
because
I'm
we
asking
actually,
you.
yeah, and I don't have a good answer for it. Unfortunately, one of our great leaders, Bernard Dreyer, who was at one point the president of the American Academy of Pediatrics, brought a bunch of us to the table because we couldn't agree on a policy. And what we agreed on, and I don't know what the new policy will be coming up because I'm not on that committee anymore, was we should consider offering Tamiflu to kids if they're sick and they have risk factors. The problem really is when you look at the hospitalizations and deaths in the kids, which again, the deaths are generally between 1 and 200 a year and for flu in kids. So it's not the big impact, but still it's 100 to 200 children in the country who die. And the hospitalizations are pretty high as well. You can't predict, as opposed to adults, you cannot predict which kid is so 50% or more of children who wind up in the hospital with flu have no underlying conditions. They tend to be younger, and those are the kids who tend to always have snotty noses anyway. So you really never know until they've gotten sick enough. So it's a tough thing. What we advocate for in the pediatric world is testing, and then if you're early enough, then offer it. But again, I would say that it's not uniformly used. And I think in particular, the logistics of testing every kid who has a febrile illness most of the time, which is not flu, whether or not to do it is still tough. It's a tough question.
Now,
We need better, again, what we said last time, we have great diagnostics. We don't always use them, but we don't have great antivirals, and we don't have great antivirals that work well unless you give them very early on. So I think we're still in that boat.
Well, Bonnie, but I'm going to go back to my question, not Tamiflu, but pediatricians are increasingly using Biloxivir. They say it's one dose, it's approved for, if you're between the ages of 5 and 12. So what are you telling parents? Are you giving Biloxivir or are you still going to Tamiflu?
Yeah, we still recommend Tamiflu as first line, but a lot of people will use, but we don't disapprove of Biloxivir. The problem with Biloxivir is you run the risk of developing resistance pretty quickly. We've been seeing that in vitro and in early studies that you can develop Biloxivir resistance. We haven't seen that widespread yet, but that's the risk. And I think, if a pediatrician is already struggling to convince a family, I think that's not a bad route to go.
Good. Yeah, it's a one dose, so you get it done. Right? Okay, so COVID. Where are we? Are we vaccinating people? What are we doing? How about Paxlovid? What are you telling your patients? Peter, I'll go back. Somebody, you get a call from somebody saying, I'm 65-year-old. I haven't had a booster. Should I get one now?
1,000,000%, yeah. I mean, more than 90% of the people in the country, as well as my own experience over the year, who've been hospitalized, they might have gotten 1 million shots early in the pandemic, but they didn't get one in the last 12 months prior to that hospitalization. So yes, but the older you are, the more urgent my recommendation is. But if you can get diagnosed and you don't have drug interactions, I'd probably try to get them Paxlovid.
Okay, good. Jason, now your call is, a friend of yours who's, 35-year-old and says, I've got COVID a couple times. I got some shots, but I haven't received a booster. Should I get one now?
I think if they're young and relatively healthy, I still think there's potential benefit, but I certainly think there's a lot less evidence for benefit than there are in older and much younger people who are at higher risk of severe complication. I think we haven't done the studies to really elucidate what the benefit would be in younger, healthy people, and there certainly are side effects. So it's sort of going back to sort of that shared decision-making model, talking about potential benefits and known side effects and whether it's worth it to them. Personally, I did get my booster, so that tells you sort of how I feel about it personally. But I certainly think that we don't have as much evidence maybe as we do for things like flu and other things about just how beneficial it is in younger, healthy people. But doesn't mean I don't think personally that it has a benefit.
How about the same individual, 35-year-old healthy individual calls you and says, hey, I got COVID. Should you prescribe me Paxlovid?
I get that call all the time.
That's what
and
I'm
I
asking
usually,
you.
and I usually talk to them about not doing it. I think we have more data that Paxlovid in younger, healthy people really doesn't offer a substantial benefit. There's the drug-drug interactions, which are a problem in some of our older individuals and even some younger people. But more than that, it just doesn't seem to have a real significant benefit in young, healthy people. And so I usually am less enthusiastic about that and more enthusiastic about vaccination. And last time I had COVID, I did not take Paxlovid. So going back to my personal views, that's sort of how I treated it.
Yeah, because but I think you're making a very important point. I frequently tell people, this is what I do. This is
That's
what I
right.
would do with myself. This is what I would do with my children or my relatives, et cetera, because that really is you should be your standard of care of how you treat people, right?
Especially when we have less data and we're sort of interpreting the data in the best way possible. I think that's how I'm interpreting the data for myself, and I certainly think it's fair to share.
How about you, Peter? What do you think?
I think I agree with Jason at this point. For those who are under 65, I'm less enthusiastic about giving them Paxlovid unless they really want it. Somebody might be, for example, under 65 who's very immune compromised. Maybe I can manage their drug interactions, and maybe they didn't get a booster. I'm not confident they have an immune response. I would give them Paxlovid.
Okay.
Or remdesivir infusion for 3 days if I was worried about the drug interactions.
Yeah, absolutely. So anything else that
Can I mention, want to hear about kids?
Yes,
please.
definitely want to hear what your view on kids.
So we're still struggling with this information, right? So if you look at the data, people over 65 are at risk for hospitalization and death, and so are kids 6 months and under. And that's the problem, right? Because where do we start vaccinating? We start vaccinating at 6 months. So the question around vaccination is, again, what we talked about before. We've done a number of studies looking at social determinants of health. And when you see young kids, they're generally living in a household with a 30-year-old or a 40-year-old. And the question is, what do you do for that child? Do you vaccinate the kid or do you vaccinate the people in the household? So I think when you're dealing with family members, especially extended families, and we're seeing the sociodemographic impact of COVID, that still hasn't gone away. Those are the people where I would recommend considering it. Now, if you're a healthy 30-year-old living on your own in the big city, I mean, I don't think that's such a big deal. But if you're a young child under 5, I'd be kind of worried about being, the possibility that they could still have illness. And, again, we did see kids hospitalized, did not have the impact that it did in the 65 plus population, but those are the people that are most likely to be hospitalized are little kids after the 65 plus year olds. And so I still think vaccination is important for the family members, and I would consider it, but I wouldn't push it hard for all kids in general. Now, Paxlovid, probably not unless the kid has underlying conditions, and definitely remdesivir if they have really significant underlying conditions.
Thank
And
you.
we'll see. We have a
Oh.
ACIP meeting in February, so we'll see what the next steps might be.
So Pemivimart, the monoclonal antibody, are you using it, Peter? Are you
We
prescribed?
actually thought we were going to use it more, but the reality is we're not. We are using it in some people, primarily people who are really, really immunosuppressed, like somebody who has multiple myeloma or somebody on, B-cell depleting agents where I'm not confident they have any response. But it is a pain. It's 1 hour of infusion, 1 hour of observation. So the threshold for treating, particularly these days when most people informally in immunocompromised will have been checking, spike the antibodies anyway, whether or not we can interpret that level. Most people have a little bit of something, so the threshold is much higher for giving, some of those monoclonal antibodies.
One other thing that I wanted to ask is around convalescent plasma, right? There's a lot of discussion whether it worked, it didn't. Arturo Casadevall and others really have pushed for this and have done a lot of studies. And finally, very recently, in fact, in the past several weeks or months, in January or so, the FDA finally approved hyperimmune plasma as a potential treatment. So What are your thoughts? I mean, would you think, given the lack of effective therapies, would you think about using
Well,
hyperimmune
so,
platforms?
as you know, Carlos, Paul Valberdine and I we're on the DSMB for active, so we can't really talk about it, but just suffice it to say that there are still a lot of open trials right now that we're monitoring on a regular basis, and there's no definitive, yeah, obviously there's no definitive answer one way or the other, or we would have shut the trials down or approved something. So, but these are, there's a lot of ongoing trials with very laborious. I feel, I want to give a shout out to people who are enrolling people because it's hard to do these trials right now. It's hard to find patients. They're all over the world. We're talking about, dozens of countries around the world with hundreds of investigators. So it's still an open question. I think as long as there's equipoise, I think it's really up to, the guidelines to follow your conscience and your guidelines. I don't think it's a yes or no question yet. I don't know what the others think.
So, it comes back to what we talked about, H5N1, right? We need better studies, we need better antivirals for COVID, and we need better vaccines for COVID. So again, at the end of the day, I want to emphasize that research is still important, and we still need to continue enrolling people in clinical trials. A question that has come up is about treatment with Paxlovid to reduce the incidence of long COVID. What do we know about long COVID, Paxlovid, their interact, both for treatment and for prevention of long COVID? Is that a compelling enough reason to use Paxlovid?
The data doesn't support it yet, but I would argue, and I think UCSF, Stanford, other places have done these trials. We did our study was part of Recover, and Recover is continuing to do more studies. It hasn't supported it yet, but the numbers aren't big enough, and the study design isn't, I think, sufficient yet to really weigh in one way or the other. But I mean, honestly, at this point, we've all heard stories. I mean, the stories are terrible. What the kinds of things that are happening to people. I think it's still worth, again, there's still equipoise here in this area, whether you should or not, but I would consider it along with an armamentarium of other diagnostic profiles on these people who are having really terrible long-term problems, including brain fog, but other things as well,
Yeah, so I
cardiac
think
and respiratory.
despite that, RCT in Stanford for Paxlovid and long COVID, there are still ongoing studies, particularly like giving it for longer, and then monoclonal antibodies, and even inside Trelvir for long COVID. And then for prevention, I think vaccines, there's more, none of the data is great, but I think there's more compelling data for vaccines preventing long COVID than Paxlovid for long COVID, although biologically, they both make sense to me in terms of reducing the exposure of the virus inside, in the, once it gets in from any method.
I think this is just a great place for clinical trials, encouraging people to enroll in clinical trials. Because like you said, we hear anecdotes about these things, but without the data, they're just anecdotes, and we never know whether people would have gotten better with or without that treatment. And so really encouraging people, especially people who are really worried and want treatment for those reasons, to enroll in these studies so we can really collect systematic data and answer these questions. Because it's important to know if it works so we can give it to more people, because if it did work, that would certainly change the way I give that medication. But if it doesn't, then we can move on to other things that Dr. Janong just listed and not waste time on Paxlovid and look for other alternatives that can help, because we have all seen patients by now who've just got terrible symptoms from long COVID who need treatment.
Yeah, absolutely. Well, let's move on to RSV. Recently, we just heard that the FDA, I think, revised its risk benefit of the RSV vaccine and said, yeah, there is risk of Guillain-Barré syndrome. So are we looking at the vaccine in a different way? Are we recommending the vaccine in a different way? What are we doing? Clearly, the recommendation to me seems like it's been a little more conservative, but Bonnie, where are you with that?
Well, we haven't, again, we're meeting next month, so I don't know the latest data. I mean, I just see what everyone sees on the FDA and the CDC website. So we're going to have a presentation in February and go over all of that data in detail and decide how whether or not we should change our clinical guidance. I suspect that we'll probably make some recommendations to just make it clear to people what the risks might be there. Obviously, GBS is a pretty, I wouldn't say a generic. I mean, it happens with lots of vaccines. I mean, we see it with flu vaccine. We see it with viral infection. In fact, it's probably more prevalent among people who have normal respiratory viral infections than it is vaccine related. So if you look at the effect size, it's much bigger for background disease than it is for vaccines, but it is still a concern, and people need to be aware of that. So, and we at our last meeting, we really spent a lot of time talking about lowering the age of vaccination or changing the recommendations for RSV. So it's a moving target at this point. But let's not forget that we still have studies demonstrating 90% efficacy in preventing hospitalizations. We don't have death data yet, but I'm pretty sure there's going to be an impact there, especially for people over 65, and especially for people with underlying conditions. For the kids, it's it's not a death issue, it's a hospitalization issue. But I want to remind people that this is the #1 cause of hospitalization in children under 5. And 2% of all children in the country will be hospitalized for RSV every year. So I still think it's a really important vaccine for the older adults, for the pregnant woman, the pregnant person, and nirsevimab. And the other really amazing thing is that we saw upwards of 75% uptake in this country with 2 or 3 months notice of these products in the pediatric and the maternal population, which is really amazing. So you see when you message the data out, where you're really careful with messaging and targeting your high-risk populations, that these interventions can really work. And I think we're going to have better and better products as we go forward. I know there are a number of companies that are looking at new vaccines, new vaccination schedules, new antivirals as well, and our monoclonals as well. And so I think the market is really going to open up here. And again, this is a testament, coming back to this issue of diagnostics. When did we ever test for RSV ever in adults? Now, as a pediatrician, we did it all the time, but our tests were really horrible. So we avoided the testing until we got PCR-based testing. So we need to really expand the diagnostic opportunities so that we can really impact this. This is a tremendous disease. Other than flu, I would say RSV is probably the most significant respiratory illness in the US and in the world, by the way. It leads to, millions of deaths a year from RSV that go undiagnosed.
Yeah, so we're getting near the end. So I wanted to ask, there's another virus that we're reading about in North China, human metapneumovirus. So what is human metapneumovirus, and why do we need to be concerned, or is this just an alarmist situation?
I could start with it. It's part alarmist and part real. One of the things is China is trying to be more open and transparent about what's going on, and that's spiraled off because it's the anniversary of, when 5 years essentially. So a lot of people are saying, is this the next COVID? It's mainly a media hype thing, but human metapneumovirus has been around, identified in 2001 in the Netherlands in children there. But when they went back, it's probably around since the 50s. And to Bonnie's point, it's really a matter of diagnostics. Many people haven't heard about it because until multiplex PCR in the ICU, we haven't really looked for it or cared about it. But now we're seeing more of it come up in people. So that's kind of where we are. We're kind of right where we are normally supposed to be around human metapneumovirus, and it acts like RSV, and people are working on vaccine.
Well, if you're a pediatrician, you know about it because we've been seeing it forever. It's just, again, but it's just one more respiratory virus for which we don't have a vaccine. It's not as to Peter is right in everything he said. It's not as bad as RSV. It doesn't cause the same degree of disease, either the severity of potential hypoxia. It really isn't that bad, although there is a spectrum, and you can see co-infections, which just that just exacerbates. So you frequently see human metapneumovirus with other viral infections, especially in children. And so I think it's probably been around in adults as well, because if you live with a child, you're going to catch it. Yeah, I agree with everything you said, and I'm not as worried about that virus, although it is important to think about mitigation of all of these respiratory viruses among the most vulnerable populations in your household.
Yeah, very important. So we got a few minutes left. Bonnie, I'm going to ask you in this last few minutes to tell us about measles. Where are we? I see vaccination rates nationwide dropping. And of course, the MMR vaccine is such an important vaccine for children, yet we're seeing many parents now not vaccinating their kids. What do we do? How do we regain confidence in this vaccine? And why is measles something that we should continue to worry about?
Yeah, so measles went back when 30 years ago, measles killed 1 million children a year in the world. And people were surprised in the US that we even have measles cases. So that's how good we were at vaccinating. And then in the 80s, we started flagging our measles immunization efforts, and we had big outbreaks in the late 80s, early 90s, and everyone thought the vaccine didn't work. And that's actually not the case. What happened is urban inner city kids were not getting vaccinated, and it flared up major disease outbreaks with thousands of kids getting infected, adults as well, and a few hundred deaths. So it does have impacts, and it's not just deaths, but there's a lot of neurologic complications. And so we could wind up going back to what happened in the late 80s, early 90s, where we start to see these outbreaks, and they're pretty devastating because who they impact are the immunocompromised for those who take care of adults. But the kids under a year or two of age are their case fatality rate is about 1 in 1,000. So it's actually not insignificant. And it's a pretty severe disease. The R naught is higher than almost any other disease. It's kind of in the 15 to 20 range. So it's a pretty high R naught. And that's why we track measles more than anything. It's high morbidity relative to other viral disease, and it's highly transmissible, and it is aerosol. It's not respiratory or droplet, it's aerosol. So we do worry a lot. I do think that we're at risk, although not significantly at this point, but given the drops that we're seeing in vaccination, we may be setting ourselves up, not just for that, but other diseases that look at the polio case that we saw in Rockland, New York a couple of years ago, and I wrote a piece about that in JID. But I think your point, Carlos, is really about trust. And I don't know if anybody else has an answer, but we are in a really dire time where social media is really taking over from science and facts. And where do we get our scientific and our factual information? How do we build that trust and have people come back and realize that what we're doing, is really, as somebody pointed out in the chat there, the reason people live beyond their 30s now is because of public health. So it is, we're all fighting the good fight, and somehow that has been lost to the public. And I don't know, people like all of us here, all of you in the audience really need to start thinking about ways that we can engender that trust in our communities. Look what's happening with the fires in Los Angeles. It is absolutely devastating. My family lives in Los Angeles. My sister was a couple blocks away from being evacuated. It was horrific. And yet, what's the first thing that we hear is, well, we're not going to give, it's all your fault. You did this to yourselves, and the degree of misinformation. And I don't want to bring another subject in, but the point is there's a lot of misinformation. If you have misinformation about climate and rain and fires, think about how we are being looked at when we're trying to, give people shots or make people come in and get monoclonal infusions or telling them to wear masks. We need to get that trust back. I don't know if you all have suggestions.
Jason, last comments.
Yeah, I think the point about measles is really important, especially because it's not frequently that people are not getting vaccinated at random. We're finding communities that are, as a group, choosing not to be vaccinated. And that's really a setup for large measles outbreaks. In 2019 here in New York City, we had over 600 cases of measles in one community. And those can spread to people outside that community who are vaccinated but at risk, people who are receiving chemotherapy, transplants and other things like that. And so those cases spread just so quickly that it's really important that we work with local communities, identify where these hotspots are, and really engage with community members to try to get those vaccination rates up, because otherwise the spread is just so rapid.
Yeah. Thank you. Peter, last comment. You get the last word.
Oh, that's such beautiful words from both Bonnie and Jason. I would just echo what Jason's saying. When you looked at, I love the New York Times analysis of vaccination rates for various diseases. But to Jason's point, what was striking to me is not the overall rate, but the rate by state to state even.
Yeah.
And in California with micro communities, when we had Disneyland outbreak a few years ago, it just spread like wildfire, but specifically in communities where it kind of went ballistic. So again, when you look at these numbers, they're average, but again, they represent a lot of micro communities.
Yes, and I think all of us are thankful for vaccines, because vaccines and vaccinations have saved millions of lives. And, you know, the main side effect of vaccination is called adults. We have kids that have grown into adulthood as a result of vaccination and clean water and many other public health interventions. So thank you very much for participating. We really had a great discussion, and I really appreciate your time. And thank you for to our audience. Amy, can you put the slides, please? I want to remind everybody the IAS-USA has a podcast called Going Antiviral. It is hosted by Michael Sag, and is now in episode 35. And this is the latest one is a great discussion with Laura Cheever, who served as the director of HRSA HIV division for many, many years and has recently retired. And we wish Laura the best, but Laura has been really an incredible advocate for HIV, and we thank her for her efforts. Next slide. The upcoming webinar from IAS-USA is going to be on weight management in people with HIV, and Selby Rangapal and Roger Badimo are going to be having this discussion. And again, this is something that many of us face in our clinics and in our patients, so should be an excellent conversation. Next slide. And finally, I want to remind you that IAS-USA is the agency that manages CROI, the Conference on Retrovirus and Opportunistic Infection. We're looking forward to CROI at San Francisco next March from the 9th to the 12th. Registration is now open. And if you plan to go to CROI, please register, secure your hotel, and it should be a wonderful meeting. And in New York, in a few weeks in March, right after CROI, we will have this called Hammer Annual HIV Management of HIV course. And again, encourage everybody to attend if they're able. This should be a really wonderful course. And IAS-USA will be doing a conference on bacteriophages, even though this is more related to antibiotic resistance. It's a new, interesting therapy that is being investigated. And I think it's time to have a meeting to discuss this interesting therapies. And if you're interested in this topic of bacteriophages, next October, we hope to see you in DC. Thank you for participating, and we look forward to hearing you in our next webinar.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.